And then I'm ready, okay?
Okay. Management of acute dental abscess. Thank you everyone for returning for the second of four lectures. Um, I hope people found it useful last week, and I hope they'll find this one useful. I know a number of people sent me questions during the week. That's great. If I can answer them, I'll try to. Where you've asked for things like the slides, they're being recorded, so they will be available as a lecture, but not as individual slides. I think the slides only tell half the story. The other half is what's said, both by me and by anyone else who's interrupting, which if they want to and it's on topic, please do so. Okay, so our learning objectives today. And the definition of acute apical abscess. How best to reduce the pain of acute apical abscess, and how to help patients choose the best management. I just want to run the first poll. So those who've got on there, it's the same question last week, which is how long have you been qualified? I just want to get a gauge for who's here. So people can log on to that and start answering the question. Brilliant, thank you. We've got at least a few people who've done it so far. Give it a moment longer. Go through the chat at the same time. Okay, so yeah, thank you for that. 15 people have put on there. So if more people join, and more people are still doing it, if more people take that link, we can get better answers as we go. Okay, right, moving on. Can you always see acute apical abscess on a radiograph? And here we've got a radiograph. I'll open that as the next question. Simple question, yes or no. I know we've got some DCPs on here. Thank you for attending. Certainly useful. There's not just dentists, and I hope you found it interesting. And if you have questions or want to ask me things, please do so.
I'm so sorry to interrupt you, Dr. Aaron. There are lots of people with their mics on, and it's very, very disturbing. So can I just request everybody to please mute themselves because I can't hear you?
Yeah, I will try and do that. Weirdly, I can't actually find it. People are going to have to mute themselves. Sorry. That was my favourite feature.
You can hear somebody eating something. It's just unbelievable.
Yeah. It was my favourite feature of Zoom during the pandemic when I was able to mute my entire family on a Zoom. But there we go. Right, share screen again. We're going to get back on with the lecture. So, okay, so we've had quite a lot of answers on that. Thank you.
The
definition of acute apical abscess. Could you please mute yourself? Talia, please mute yourself. Thank you. Okay. Um, we get the definition from the American Association of Endodontics. Colleagues for Excellence. It's from um, the fall or autumn of 2013. Now, last time we spoke about the need to make a pulpal and an apical diagnosis. Just to repeat that, pulpal, normal, reversible pulpitis, irreversible pulpitis, which is a misnomer because of biodentine, but hey, symptomatic or asymptomatic, pulpal necrosis, previously initiated treatment, like someone started a root filling but not finished it, previously root treated. Then you've got the apical diagnosis, just to repeat them quickly. You've got normal, you've got apical periodontitis, which can be symptomatic or apical or asymptomatic, chronic apical abscess, and acute apical abscess, and then you've got things like condensing osteitis as well. The definition. Acute apical abscess is an inflammatory reaction to pulpal infection and necrosis. Nicola, please mute yourself. Is an inflammatory reaction to pulpal infection and necrosis characterized by rapid onset, spontaneous pain, extreme tenderness to the tooth to pressure, pus formation, and a swelling of the associated tissues. There has to be a swelling, otherwise it's not an abscess. There may be no radiographic signs, so most of you were correct with that, of destruction, and the patient often experiences malaise, fever, and lymphadenopathy. It's something a lot of dentists get confused about. I can't see anything on the x-ray, therefore they mustn't have an abscess. It all relates to the 3D effect. Your bone's 3D, the x-ray is 2D. We have on there about they may have fever. So how do we know someone's got fever? Obviously, you can sort of ask them, you can put your hand on the back of their head, the back of your hand on their head or something. But here's a question. How often do we take a temperature for people? Do you do it regularly? Perhaps occasionally? Or not since COVID? If you're a dental nurse, I mean, the question is, well, a dental nurse could do it just as much as a dentist does it, but how often is it done in your clinic? Those are putting the answer in the chat. Great, but it's far better if you can go on to VVOX, because then we can actually tabulate what's going on. Okay. So how do I take a temperature of patients? We've got the forehead things, and we will accept that they're not very accurate. Very often, I remember during COVID, you'd go somewhere, they'd take your temperature and they'd say you're normal. You look at it, it's 33 or something. I'd be dead if that was my temperature. So what I always have done, we calibrate it. So I zap myself, I zap the nurse, or she zaps herself and then zaps me, and then we zap the patient on the forehead. So usually speaking, myself and the nurse will have a very similar temperature. We've been in the room, we're both fit and well, we're not diseased, and with fever, we wouldn't be there. If the patient's got a very different temperature, that's a sign. If it's higher fever, if it's low, we could be something severely worrying, although if they've just come in on a cold day, it could just be skin temperature. So this is the research I had published in 2018 in the BDJ, and it was primary research. It was done from scratch in general practice. It's something I'm very proud of. Could you mute yourself, please? EF phone, please mute yourself. Thank you. I might start throwing people out if they want to talk over the lecture. Sorry. If you've got anything you want to say that's relevant, please interrupt. Okay, so some thank yous for the research. And firstly, obviously, patients who participated in it. To some people, my practice manager, my partner, and it's just London, who were very supportive of this, and specifically the dentists and the nurses who helped to recruit the patients. No way I could have done any of this on my own. Professor Steyer, um, who, although much of the work is done by myself, if I didn't have the help of somebody like him, I would have got nowhere with it. Doing research is difficult, but is very rewarding in terms of, learning how things work, learning how to read any other research for a start. Um, Mostly, I want to thank people who have read it, but more importantly, people who act on it. If it just gets written and nobody changes anything, it's a waste of time. If people read the research and do something and treat patients better, that's the whole point of it. Okay, so the objectives of the research paper were to determine if dentists are successful in reducing pain from acute apical abscess in an NHS emergency setting, and to determine if different management strategies result in different levels of pain reduction. That's the key bit. I want to know what works, what doesn't work. The design was a single centre prospective trial in a purpose-built clinic, a dental practice, for want of any better description. For what it's worth, we're based in a health centre, but like any other dental practice, we've got the same stuff everyone else has. Patient management was agreed between the dentist and the patients. We weren't putting people into different categories randomly or anything. The dentist and the patient decided which category they wanted to go into. And the patients were then grouped into one of three groups. Those that had drainage as well as antibiotics. Where are we going? We're going the wrong way. And those that only had antibiotics. So you got three groups. And my expectation was a certain thing, but it's not quite what came out. So you start off, we needed to get standardized diagnosis, and that's important for all patients, but it's also important in research that you're clearly defining the group of people that you are with. If that's not defined, then the research is going to struggle for its validity. We need a medical history. We need a dental history which is relevant to the complaint. We need a proper, write down of what the complaint is. A clinical examination needed to be done with the testing. And I can't stress this enough: percussion, palpation, pocket depth, pulp testing of every relevant tooth. Long cone parallel radiograph, and then additional tests. We've got things like biting a cottonwood roll, tapping the zygoma, selective anaesthesia, test cavities, which I use from time to time, and taking temperature, which we've worked out. Just under half of people are doing at least from time to time. We need the standardized diagnosis so that somebody else, in this case the researcher, can be certain, or as good as certain, that the patient did indeed have an apical abscess and not something else. This sort of thing is also useful in medical records, that somebody else can be certain of what that patient had at that point in time. Maybe yourself at a later date, maybe somebody who's dealing with a complaint, maybe your colleague a week later, to know what's going on. That's when a patient comes in and says to me, "Oh, I had an abscess, or I had this, I had that, I was given antibiotics." Right. I don't know whether that's true or not, because half the time, "Oh, I had antibiotics, I must have had an abscess." And you look at the tooth and it's still vital. So what they had clearly wasn't what they thought they had, or the dentist thought they had. What was the methodology of the research? We had a pain quality assessment scale. This wasn't something I designed. This came from multiple pain studies that are done in all sorts of places. You have 20 different questions about different types of pain. Is it throbbing? Is it itchy? Is it deep? And you had a scale of 1 to 10. So 1, no pain, 10, unimaginable pain, and you mark on the scale where you want to go. The patients had to answer the questions prior to seeing the dentist, and again 24 hours later. And getting that within a reasonable window at 24 hours was hard work. And I remember seeing research done where somebody had seen 400 patients and they had followed up all 400 and they'd all done it 24 hours later. And I read that, having done this research, and think that research is so flawed that it's simply lying. There's no way anybody got everybody to answer those questions 24 hours later. So we had these three groups. So we've got the antibiotic-only group, the drainage-only group, that's drainage being an extraction, an extirpation, or an incision, and the antibiotics plus drainage. So belt and braces, we used to call it. What were the results? Firstly, we can successfully reduce pain caused by acute apical abscess in this practice environment. Great. We know it works. Now, very often we never follow up patients, so we didn't actually know how much pain or not pain they were in afterwards, other than if they called back to complain. But we know we can get rid of pain. We found that the pain reduction was significantly greater if drainage has been carried out. So drainage, taking the tooth out, extirpating a tooth, incising a swelling, if someone's got an abscess, is going to reduce pain much better than giving them antibiotics. What the surprise was is there was no significant difference if antibiotics are given in addition to drainage compared to drainage alone. So belt and braces wasn't worth doing. Saying to somebody, I'm going to take teeth out, but I'll also give you an antibiotic prescription, it would help more to do both, turned out to not be correct. The practice environment was well stocked, well equipped, the staff were well trained, at least I like to think they are, and we had about 20 to 25 minutes, probably 20 at that point in time. Um, you know, most of us have clinics that are well stocked and reasonably well equipped, to a certain level. We didn't have anything, we're not running particularly fancy to do this. And the appointment times back in 2018 were much lower than they are now. The conclusions to the research: dentists can successfully reduce pain caused by acute apical abscess in an NHS emergency setting. That doesn't mean you can do it in a 5 minutes clinic in GDS if that's all you're given, but it does mean if you've got 20 minutes, 25 minutes, it is doable. And acute apical abscess should be treated by drainage wherever possible. In terms of pain, there is no additional benefit in prescribing antibiotics. We will come to when antibiotics should be prescribed later on. I don't know if Oma's on the call. She sent me a message earlier saying that she didn't need to come because the answer's so clear, but it made me laugh. Okay. In other research papers, I then got this got cited, which made me feel good. I don't know if it helps anyone else. If anyone's not heard of Wendy Thompson from the University of Manchester, she's probably the guru for when to prescribe antibiotics in the UK. So, what are our recommendations? Standardized diagnosis got to be correct, got to be doing the same thing every time. And I keep repeating myself because this is critical. We need to make sure we get our diagnosis right. We need to establish drainage if at all possible. No point giving antibiotics unless there is spreading infection. I'll come to what that means in a moment, because reading records of hundreds of dentists over the years, we see these things are defined rather loosely by a lot of people. So let's come to a clinical case, and there's going to be a few questions here. Lady in her mid-20s, she's got asthma, smokes 10 cigarettes a day. Probably shouldn't do that in any case, but shouldn't do it. She's got asthma, but hey, that's another story. She's got severe continuous pain. Lower left 8 has gross caries and the tooth is unopposed, not biting anything. TTP, the sulcus is tender and swollen. The pocket depths are normal. Endophysitive. And there are no signs of spreading infection. David and Kai, turn your sound off, please. So we've got no signs of spreading infection. Here's the X-ray. What do we think? What is our diagnosis? We're going to start a new poll. What is the pulpal diagnosis? Because obviously we've got to have two diagnoses. Pulp and then apex. Okay. So there's a swelling. The tooth is endofrost negative. It's TTP. TTP means there's some sort of problem at the apex. The pocket depths are normal. Remember, we have a swelling. What is the apical diagnosis? I was tempted to put in a case that wasn't acute apical abscess because, having spoken about it, it ought to be fairly obvious that the answer is going to be acute apical abscess. But I didn't. The diagnosis here is a necrotic pulp and acute apical abscess. I'm not sure. A lot of people have put down they thought that there was pulpitis here. Pulpitis is a vital tooth with some sort of sensitivity. Once the problem has resulted in a swelling, the pulp has to be necrotic. You can sometimes get odd cases where one root's this and one root's that, but this one's necrotic. So the patient has been referred. This is patient seen in the emergency dental clinic. The patient's been referred for IV sedation extraction by their own GDP. Why? I don't know. Patient wasn't particularly nervous. As the dentist was nervous. Extraction doesn't look particularly difficult. We all know the problems of NHS GDP general practice, and I appreciate that may have influenced the decision. But the patient's had pain, seen their own dentist, and is now in the urgent care clinic. So the options given were to do nothing or to extirpate the tooth. Can anyone let me know what is missing here? What option has not been given that really ought to be given?
There's no opposing tooth, so extraction.
Exactly. It's a pretty straightforward case, I would have thought, but wasn't offered. So the dentist accessed the pulp and then found the canal difficult to locate. Okay, I mean, it's a slight angle, so maybe. So I'm just struggling with the polling thing. I'll go back into that in a moment. I'll come back to that in a moment. They put Ledimix and a temporary filling. Ledimix is useless in a necrotic case. It's only for hot pulps. They gave amoxicillin in the absence of spreading infection against the guidelines for 5 days, as they were unable to fully negotiate the canal. So the dentist not being able to get down fairly wide open canals is not really an indication for antibiotics to behave. And a week later, the patient came back with the same pain, the same diagnosis, and the tooth was taken out very easily. The patient had 2 weeks of additional problems. Please mute yourself.
Doing this, you know what I'm saying? Sorry, as in that bollocks, you know, like.
Thank you.
Yeah, I can imagine this.
Anita, please mute yourself.
So slow, that's the thing. Oh,
Thanks, Santa.
Anita, I'm going to give you one more warning. If you don't mute yourself, I'm going to throw you off the call.
Better to stay active.
Thank you. I've thrown off the call. Sorry about that, everyone. All right. Can the other person who's talking please mute themselves? Thank you. Lisa, Lee, would you please mute yourself?
Sorry.
Thank you. All right. I apologise for this, everybody. Right, we'll go back to the call. Right. So, 2017, I had this article in Primary Dental Journal from the faculty. What are the key factors in treating the emergency dental patient? And I said that we needed 20 minutes, but ideally we need 30 minutes. I wrote that in rather than expectation. I did not expect at any point that we would get that amount of time. Pandemic came in and we got 30 minutes and we've kept it. Now, that's not every NHS clinic, I appreciate that, but in urgent care, that's what we've got in many areas. I don't know, there may be some areas where it's not, but that's what we've got at the moment. But the commissioners are always looking at it because there's a lack of access. And they think, well, if we give 20 minutes, we get 3 patients in now rather than 2. The national guidelines have changed from 15 minutes to 20 minutes, which is an improvement, but it's still not enough. And we need to use the time we've been given to treat patients correctly. If we use the time, we can persuade the commissioners that this is what we need and this is what we want to do. So the reasons not to give antibiotics, I put this slide up last time. We have this global problem. By 2050, they predict there could be 10 million deaths a year globally because of antibiotic resistance. COVID caused about 7 million deaths. So it's that sort of scale. The main reason not to give antibiotics dentally is they don't work for the presenting diagnosis. Obviously, in some cases, you should give them, but in some cases, they're not necessary. The resistance in the individual, we get resistance in the community, which is this problem. We get allergy and anaphylaxis. It's rare, but it happens. Most people that say they're allergic to penicillin probably aren't. Which is a whole separate conversation, but it upsets your gut microbiome. In severe cases, we get C. difficile, which I'll come to in a moment. If you prescribe antibiotics in a case where you shouldn't have done and something goes wrong, which is where we always get caught when something goes wrong, you've not really got a leg to stand on. And if you've got a clinical governance program at practice like where I am, this is an issue. If someone's prescribing antibiotics all the time, we've got a problem with that. So what is C. difficile? There's an article there from the Virulence Journal. It's a gram-positive obligate anaerobe, which might mean something to some people. It causes diarrhea, colitis, and toxic megacolon. Weirdly, antibiotics are both the cause and the treatment. It's got to find the right ones. So giving a broad spectrum antibiotic, things like clindamycin and amoxicillin, lead to severe and unpredictable disorder of the gut. And leave it a state where C. difficile will thrive. It's the one that doesn't get killed by the antibiotics. And this is why we're supposed to not give amoxicillin when we're prescribing. We're supposed to give phenoxymethylpenicillin. It's less likely to cause this. So how many cases a year do we get? Anyone want to shout out any ideas? I've not done it as a poll, but anyone got any ideas of how many cases a year? The answer is 13,000. So not insignificant number. How many people are killed by it each year in the UK? 1,800. It's not nothing. It's a significant enough issue. I don't know how many patients are killed by anaphylaxis to antibiotics, but we don't see death. The average hospital stay is the one that really shocked me. That people with C. diff are in hospital for 37 days. It's a long time. So when do we give antibiotics? This is the microbial prescribing tool. You can read this, in your own time. It's available from all sorts of places, BDA, the faculty, and whatnot. And again, it mentions phenoxymethylpenicillin, which is a first-line drug. There has to be spreading infection. Okay, so what is severe swelling? What is spreading infection? What is just... So spreading infection, severe swelling is not the same as a raised lymph node here. It's a big swelling. The face is bigger. It looks different. It's not just a small swelling of the gum. It's on the face. What's trismus? Trismus requiring antibiotics means the patient can't open their mouth. It's not, it hurts a bit when I open really wide. It's, I can't open my mouth at all. How often should we take this patient? So somebody's not muted themselves. How often should we take a patient's temperature? It's not every single patient, although it might be a good habit to do so. But certainly, if somebody's got is talking a fever, or you're thinking about whether you should give antibiotics. If they haven't got fever and they haven't got swelling, Why are we giving antibiotics? What's the reason? And noting that they haven't got a fever is a good reason to say, that's why I'm not giving antibiotics. You don't need them. Malaise is when you're feeling unwell throughout the body rather than just a toothache. You say somebody, I see you haven't slept, I see you in a lot of pain. The pain's here, yeah? Or is it, do you feel ill everywhere? Do you feel weak? When you've got flu or COVID and your legs have gone. It's that sort of thing. That's the time that someone's got spreading infection and that they need antibiotics. And if you're prescribing antibiotics, we always need to start thinking about sepsis. Because that's not every antibiotic case, but certainly, we do need to start thinking of it. So follow-up calls to patients. How often do people ever follow up? How often do people make a phone call to the patients afterwards to see whether they've got better? Now, I had this as a poll, but unfortunately I've been logged out of the poll trying to shut people up, so I apologise for that. The answer is, at my clinic, we do call up, or we certainly try to call up every patient who's been given an antibiotic. One way of doing that is not giving out too many antibiotics. It reduces the amount of calls you've got to make. But if you make a call and the patient's better 2 or 3 days later, you can tell them to stop taking the antibiotics. The idea of having to finish a course is old school. It's no longer current guidance. So sepsis kills. And I hope everyone's got these red posters up in their practices from the Sepsis Trust. You can download them. How many versions do we have? It used to be 2. The answer is now 5. There is one for adults. There is one for ladies who are pregnant, one for the under 5s, one for 5 to 11, one for 12 to 15. You need to know there are different age groups because when it comes, nobody's going to remember all of that. It tells you what to do. But the key question is, when do you go to the sepsis poster? And the answer is when a patient looks unwell compared to what people normally look like. We've all seen lots of patients who have got toothache, who haven't slept all night. If a patient looks worse than that, start thinking sepsis as a possibility. Are there any red flags or even any orange flags, amber flags? 50,000 deaths in the UK per year, and that number goes up every time I look at their website. I have no idea how many are linked to dental infection, but it certainly happens. If anyone happens to know where I can find that stat, I'd love to know it. So we've got another clinical case here. A male, mid-20s, 30s, smokes 20 a day. Had a facial swelling yesterday, less bad today. Gross caries with a large temporary filling, which is booked from the chemist, low at 7. Oral hygiene needs improving. Tendon node submandibularly. Percussion, 7 TTP, 6 and 8 not TTP. Palpation of the sulcus, tender. Pocket depths, deep. Endofrost cold test, 6 and 8 positive, 7 negative. Is the X-ray. Clearly he's got a few different problems. I'm not running a poll on it, but he's got an abscess because he's got a swelling, facial swelling. The tooth is non-vital. We can't tell that off the X-ray. We can tell that because we did the cold test on it. So our diagnosis: necrosis plus apical abscess. The options are discussed with the patient. Extraction is the option here. I guess somebody might want to consider a root canal treatment, but I'm not quite convinced I see why. And then he needs further care. He needs perio treatment. He needs fillings. Took the tooth out all uneventfully, and we booked him another appointment for the necessary care for the other stuff, but he didn't turn up. You can lead a horse to water, but there we go. We can't do everything. But by getting him out of pain on that one occasion, and for that patient, I guess he's happy. He'll come back when he's got the next toothache. The next clinical case is a complaint, which it's not a patient I saw, but it's a patient we've seen in my clinic. I have done a lecture where I spoke about a complaint I had, which always feels different. It always feels much worse when it's personal. When it's about someone else, I can speak to the patient. I can try and defend the dentist often, if the dentist has done the right thing. When it's about me, much harder. And I appreciate, I try to appreciate that when the complaint's about you, or that it is, we all take it personally. Here, the patient saw 3 different dentists. The first dentist, pain low right quadrant, 8 out of 10 pain, quite a lot of pain. TTP low right 6, sulcus tender, there's an abscess is the way they put it, I guess. Pocket depths, NA. Cold test, NA. Additional test, NA. What does NA stand for? The low. NAD stands for not actually done, potentially. I mean, it's supposed to stand for no abnormalities, but not actually done, I think, is often the case. NA, not appropriate, not applicable, can't be bothered. I'm not sure what it means. It means something. The dentist also noted there was caries upper right 6, broken filling and shadowing, and the bifurcation of the lower right 6, which is where the abscess is. Diagnosis written down: irreversible pulpitis lower right 6. And as there's an abscess, prescribed antibiotics. It's all rather weird. The indication for antibiotics is a spreading infection. And having 2 diagnoses on your notes doesn't look good. So advise the patient to come back another day and see someone else to have the extraction done. Interesting. However, the patient was happy with this first dentist, and in fairness, the dentist sent me a lot of reflection on the case, and there are things I've left out for the presentation. We've all got multiple stakeholders, though. We've got to make the dentist happy. We've got to make the patient happy, perhaps your boss happy. You've got to make regulators happy and everyone else happy. And you can't always achieve everything. Dentist 2, this is the X-ray. So we've got a deep filling, we've got secondary caries, we're close to the pulp horn's been obliterated distally, we've got some sort of apical something going on. Dentist 2 and 3. 8 days later, dentist 2 saw the patient. The abscess and the swelling was still present, even after the antibiotics. Who would have thought that drainage works better than antibiotics? Anyway, the second dentist felt the roof was a bit curved and felt it was a difficult extraction, so they did an incision and drainage. There's your X-ray, a bit curved. Well, yes, it is a bit curved. Is it difficult? Well, each to their own as to how difficult that is. We'll come to that in lecture 4 about what is difficult and what is not, and when to treat, when not to treat. It's well worth, I think, coming to that one. We'll talk about all the medical emergencies in that as well, in terms of the medical issues and what relates to when you can and can't treat medically, when you would treat on a healthy patient. So anyway, this dentist did an incision, they drained it, they said, ideally you'd put in your notes, pus came out, but it did. So anyway, they did a permanent filling on the upper right 6, which was also bothering the patient. They referred the patient for extraction by tier 2 because they thought it was a difficult extraction. And the patient was extremely unhappy with dentist 2, who had done all the work. 8 days later, they came in, they still had pain, and a third dentist extracted the tooth. Now, in fairness, this dentist worked in oral surgery as well as with us. We've all got different skill sets. This is what you can learn from this case. So some people, in this case, dentist 1, knew how to make a patient happy. Dentist 2 did a hell of a lot of good work for that patient. And dentist 3 actually sorted out the problem. We want to be a bit like all of them. In this case, the patient complained repeatedly to the NHS Complaint Service, and repeatedly the NHS Complaint Service backed these dentists. Our regulators sometimes get a bad rep, but sometimes they are on our side as well. So, Nudge, Richard Thaler and Cass Huntsbean. Anyone read it? I hope somebody has. It's about choice architecture. Richard Thaler in 2017 won the Nobel Prize for Economics, and he was a colleague and a student of the great Daniel Kahneman, who wrote Thinking Fast and Thinking Slow. How can we encourage the behaviour we want from patients? Put slightly differently, how can we encourage the behaviour we want from dentists? Different question, but similar. So, framing and nudging is the answer to that. Anyone got an organ donor card? Does anyone who agrees with organ donorship, i.e. giving your own organs or the organs of your family? I was going to put this up as a poll. My expectation is, do you agree with organ donorship? We've got 125 people on this call. The vast majority agree with organ donorship. So we're going to change subject slightly, but hold that in your head. Which of these countries are similar? Austria, Ghana, Peru, Sweden, Germany, Tajikistan, and Denmark. You're looking for two pairs of countries. It's not a trick question. The answer, well, Germany and Austria, Sweden and Denmark, you'd expect them to be pretty similar. So what are the organ donation rates in these countries? This data is quite out of date, but it doesn't really matter. Would expect Austria and Germany to have similar organ donation rates. Would expect Sweden and Denmark to have similar organ donation rates. What are the rates? Germany 12%, Austria 99%, Denmark 4%, Sweden 86%. What's going on? The answer is framing. How do you ask the question? In the UK, we now have an opt-out system. We used to have an opt-in system. Presumably, Germany and Denmark had opt-in, Austria and Sweden opt-out. You can choose, but if you don't make the choice, we're going to assume that you're opting in. My understanding is that when these things happen, the doctors still speak to the family, but the assumption has flipped. Now, I think, okay, I understand some dentists like cars. I've not got a huge amount of interest myself. When I last bought a new car, I was accused by my wife of being mad because, having immediately bought a new car home, I decided to go out for a bike ride rather than driving this thing. But there we go. And it was cold and dark, but again, each their own. So what would you choose when you're buying a new car? You can get a standard car, standard brand, certain cost, basic radio, seating, safety features. Alternatively, you can have an upgrade. It's a bit dearer, but you don't have to sell a kidney. I've rewritten this and made it a bit politer because some of the language was a bit fruity when I originally had presented this in-house. It's got state-of-the-art car entertainment. It's got improved cushioning, better back support, all of the most advanced safety features for you, the driver, and for your children passengers. It's a nudge. Which one are you going to choose? The answer is the second one. How you frame the question will determine what answer you get. Not from everybody. For some people, affordability, price is key, and they're going to go for the first one. Most people will go for the second one when the question is put like that. Hold that again in your head. We've got anchors to think about. An anchor sets the basis for all that follows. Think of an item of unknown cost. This item costs £100. How much is it worth to you? Well, it's worth £100 because that's what Scott said. Anything else is judged against this. 105, well, I've overpaid. 95, I paid too little. A colleague of mine, when I asked this question to one, said, I'll give you 10. I said, why 10? And she said, look, you and I both come from the Middle East, and in the market, we start high, we start low, and we'll eventually end up somewhere in between, but I'm not starting anywhere near 100. Okay, but the idea is when you put an anchor, it holds the ship in place. And if you put the anchor in the wrong place, the ship will go astray. What's the relevance? Why am I talking about all this stuff? Got to bring it back to emergency dentistry. Well, I'm going to start off by bringing it back to dentistry in normal practice. We offer a new patient. Mixed practice, you can be NHS, you can be private. It does still go on. So it's £26.80 for an examination. You get x-rays, you get scale and polish included in that, band one. Or at my clinic, everyone has their own prices, 121 quid, you get an examination and cleaning plus extra for the x-rays. For the more expensive one, you get to spend more time with the dentist. Now, the last thing anybody wants to do is spend more time with a dentist. Again, I've cut the fruity language out. So what can we say to somebody? What is the difference? We all sort of know it. I mean, the exact wording is something different. If we've got any dental receptionists on, dental nurses, but dentists are useful as well. What are we, a new patient, you have an examination. We're going to fully discuss with you what you want for your mouth. What's right for you, not just look at your teeth and say you need X, but what's right for you. How do you want your dental care provided? And everyone's different. Do you want cosmetics? Is cosmetics important to you? Is function important to you? Is prevention important to you? What's important to you as a patient? We need to know what our patients want. It's certainly in general practice. In emergency care, we may not have the luxury of time to do that. We're going to examine your teeth. We're going to examine your gums and mouth fully. We're going to use state-of-the-art equipment, whatever it is each one uses. I've got a microscope, but everyone's got different kit. We should be investing in good kit for our patients. Best diagnose what's happening in your mouth. We're going to discuss all the options with you. You're then going to get an appointment with a hygienist. The hygienist is going to thoroughly clean and polish your teeth. She's going to teach you how to prevent dental disease. Or we can do the same, but we're going to do it a bit quicker. We're going to do some, but not everything. With lesser equipment. We're going to discuss some options. We'll give your teeth a basic clean because we're reasonably okay, but no one's going to do a polish on the NHS anymore. I mean, some people might do. Scale or polish, maybe? I don't know. So if you frame it correctly, people will choose differently to if you frame it wrongly. What's the relevance to emergency dentists? This is the third learning objective we have. How do we get patients to do the right thing? So what are the options available for the emergency dentist? This is a patient with an abscess. Here's our x-ray. What are we going to do for them? We've got various options. No treatment, extirpation, extraction, incision of a swelling. You can catch a frog under a full moon, open its mouth, spit into it, and saying, "Frog, go and take my toothache with thee." I don't know the original Latin, but I found that one as a great method for dealing with an abscess. I don't know if it works. I haven't seen any research on it. I'm not convinced myself. We can extract the lower left 5. Now, I've included that because it's about as daft as the frog one. But it's an option. I've got to go through all the options with patients. And then there's an ancient Egyptian remedy where you put a dead mouse on the tooth. And again, you wonder quite what the ancients were thinking as to whether, they would have presumably seen that these things didn't work, or were they working on the idea that you only went to them when the pain was so severe, and the pain would often get better on its own. That abscess burst within 48 hours of putting the dead mouse there. So maybe it worked. Maybe it was a great idea. Antibiotics, they're also an option. Now, there is a place for them, but very often that place is somewhere near the frog and the mouse. So, doctor, what are you going to do about my pain and the abscess and my swollen face? How are you going to help me? We're going to lay an anchor. We're going to frame this question. So what's going to be done next? Well, how are we going to do that? How we frame this, where we put this anchor is critical. You could say, firstly, there are a number of options. I could do nothing. Well, the patient thinks you're an idiot. You can say, I'm going to give you antibiotics. That's one of the options. Wonderful, thank you. The patient's going to think, you've got a highly clever dentist who has spent 5 years at medical school giving me the best medication, the right antibiotic, and I don't need any of that horrible, painful dentistry that I was worried I was going to need. I think the dentist who's offering that as a first-line option is either a fool or a crook. There we go. So how would I do it? How would I frame this problem? So you need to have the teeth out. It's very simple. That's what we've got to tell our patients. We've got to be honest with them. The patient might then say, can I have antibiotics? Well, why? Because I would, given the choice, if all things equal, I'd rather have magic pills than treatment. Fairly obviously, because magic pills are maybe nicer to take. Well, my answer to that is the magic pills don't work for this sort of problem. You don't have any signs of systemic infection, for example. And I say to them, all the research and guidance shows that the best way to get you out of pain and stop the problem getting any worse is take the teeth out. And obviously, if they've got spreading infection, different story. You may well decide they need antibiotics. That's not unreasonable. We are allowed to prescribe, and we should sometimes. Are there any other options? And patients often ask that. They're anxious. They really don't want the tooth out. They know it's going to hurt, and they don't want to be another tooth down. And it feels like you're getting older, one step nearer the end. And the answer here is, well, you can. The only other sensible option here is you can continue taking painkillers, but the only option that's going to work is to take that tooth out. Now, if you think there's another option, if you feel an extirpation to buy another day is worth doing, okay, fair enough. But in this case, my view is going back to the X-ray. That tooth is beyond saving, and unless there's some sort of medical indication, it should come out. Obviously, the patient doesn't have to choose it, but we don't have to offer every single option, including the one by the Romans and by the Greeks, or the Egyptians, it was. Sorry. The next lecture we have next Friday is on complex diagnosis and how to manage in 20 minutes, 12:30 next Friday. The picture that's flashing up is a warning about the dangers of smoking and drinking. And if anyone knows the character, it's a picture I enjoyed taking. I got in a lot of trouble for taking it, but there we go. It's Bing Bunny off BBC. Okay, thank you very much. Now, if anyone's got any questions, please ask. If anyone wants to ask questions later, they can email me, scottaaron@hudc.co.uk. I'm going to look through the chat and see if anyone's got anything written in there. If you got any questions you want to shout out, please do so.
Hi, can you show the first case, please? The first case with the acute abscess, please.
Yeah, will do. Who's speaking, by the way?
It's
Negar.
Negar.
Yeah. Hi. Share screen. This is the lower left 8.
Yeah, with the acute abscess. So, well, in this case, that it has swelling and it comes to you, but it matters how many days they have this inflammation in the face. So if the patient says 7 days, this is the 7 days, what you do, and if it says it's the second day, what you do.
In this case, and say it's not a patient I've seen, but we're assuming the tooth is unrestorable based on the amount of decay. And even if restorable is of little point, it's not going to be a useful denture abutment, and it's unopposed. The tooth needs to come out. I'm not sure whether it really matters how long they've had it.
Yes, my question is about antibiotic. So I have no doubt that it has to come out, that one. But in the matter of antibiotic, do you give antibiotic and then extract it? Or because if you don't have time and you have all of your diaries full and it's only 5, for example, 15 minutes emergency, you have time. Do you give antibiotic? And then after 7 days, if you have time, you do that? Like what we do usually in UK, or no, you just...
No. The patient doesn't have spreading infection, so there's no indication for antibiotics. If you haven't got time to see the patient, don't see the patient.
Yeah, but if it has swollen face, you still don't give it until you if it has trismus, you give antibiotic.
The patient hasn't got swelling face. This patient has got swelling in the sulcus.
Oh, not a face. Okay, so my question is about the face. If it's on the face, you're going to give the antibiotic. Am I right?
If the patient had a swollen face, I would want to get the tooth out all the more so, because that is what's going to deal with their problem. Now, there are times when a patient has spreading infection and you haven't got time or something like that, then an antibiotic is indicated. But it is a very distant second best. A patient with a swelling, we want to get that tooth taken out.
Exactly.
Sometimes a patient can come in with a huge facial swelling. You incise it, which is very quick to do, or you take the tooth out, and a huge volume of pus comes out. You see the patient's face go from here to here straight away, and the patient says, "Ah, I feel so much better already."
Yes.
And that patient does not need antibiotics at all.
Well, I had
Sometimes
a case.
down the stroke of the swelling. You go
Yeah,
ahead.
yeah, I had a case that if it's the swelling, well, we couldn't do the drainage because it went toward the face. It was not clear what we can drain it. So there was no possible to drain because it was like very chronic. I tried to
Could
do
you not
the
prove that?
drain. I did the drainage, but nothing came out. No pus or nothing came out. And then I was like, okay, so I have to do extraction as soon as possible. But in this case, I gave antibiotic after the drainage.
Yeah.
Is it the right
Yeah.
thing?
Yeah, if someone's got a facial swelling, so they've got spreading infection, you've incised it or you've extracted the tooth, and they've still got the same hard facial swelling that was there to begin with, then yes, antibiotics are indicated.
All right.
You can do both. It's not saying you should never give antibiotics, but you should always be aiming for drainage. And sometimes you'll take the tooth out and you won't get drainage. You'll extirpate a tooth and you won't get drainage. You put the files in, you get to apex and nothing comes out. It's bone dry.
Yeah.
In those cases, you need to think of what you're doing secondary because the first thing hasn't yet been successful. And I appreciate the issue of time, and it is a problem in NHS general practices. It's probably a problem in private practice and everything else. But we need to try to organise our clinics that we have time to at least treat some people. And saying to people, just come in and we'll give you a quick script, doesn't help. We're not getting any better a week later.
Thank you.
Hello, I have another question. Can I ask you?
Yes, you can. Essen, go ahead.
Yeah, I just want to know that if patient comes and then patient has a very huge abscess with heart situation, like huge and heart abscess, do we still need to do drainage or just give antibiotic and send her to someone like who can deal with?
Well, if you send them to someone, who's that someone? The specialist who's going to take the tooth out? If you can institute drainage, you should. Obviously, there may be cases where you can't. Let's say someone's got a huge swelling to the point they can't open their mouth. Clearly we've got a problem here. We've got spreading infection, no surgery case.
Okay,
They need
she
to go to
can
a hospital.
open. I see. She can open her mouth very well, but the lips were like, where the tooth is 2.1 to 2.5. It is a very huge abscess and it is very hard. And I don't want to have a complication. That's why I didn't do, but I just want to know that is this a good thing that I did or not? Because I did a referral to see someone who has more experience than me, but meantime I give the antibiotic.
The someone who's more experienced than you is definitely correct. I don't know how experienced you are. Now, should you give antibiotics is a separate question. If you have a patient where you cannot institute drainage, for example, it's too difficult, there's no incisable swelling, and the extraction is just beyond you for whatever reason, you're newly qualified or it's not your field of dentistry, and you have, let's say, another dentist in the room next door who is quite capable of doing it and has the time, that's a bit of a luxury, but let's say that's going on, then no, of course, you just refer it straight to your colleague next door and you wouldn't give antibiotics. If, however, there is going to be a time lag, then antibiotics may be indicated. But certainly, if you've got such a severe infection, you'd want to be in touch with the on-call at the hospital to try to get that dealt with very quickly, because it sounds like quite a severe case. It's not a case of here 10 days worth of antibiotics and we'll see you next week. It's got to be dealt with quickly.
I see. Okay, thank you so much.
I've got a question.
Thank you.
At what stage of how much swelling and where you're going to need to give the local anaesthetic injection do you decide that there's too much swelling to do the extraction with good anaesthesia and you're worried about spreading the infection or pumping up the swelling and spreading it with the local anaesthetic?
I'm not remotely worried about that. It's an old one, and I was taught it at uni as well that you can't put the anaesthetic into the swelling. But it is papers I've read on this, it's extremely rare, if at all, that actually causes any damage. To some extent, I mean, if I see a swelling and I'm trying to think of that, I'll often try and inject around it, so mesial or distal, or mesial and distal plus palatal or whatever. But if you inject straight into the swelling, what you're in effect doing is lancing it with a small scalpel. Very often, very often I'll inject straight into the swelling, and what happens is a whole load of pus comes out and the swelling goes. I've done my incision already. I'm not concerned about, the swelling's too big, I need to give them antibiotics first at all. It's get the tooth out, try to get, and that swelling will often go down there, and then if it doesn't, then antibiotics are required, because you've got spreading infection, and you've got to prevent them potentially getting sepsis.
Okay, thank you.
Right. I will make sure I put the auto mute on for next week. I apologize. I'm reading through the comments here. Okay. So the question about thermometers, not since COVID, a lot of people have written, which doesn't surprise me. Where have we gone? Where are we going through this? I don't want to sing a song while waiting. Okay. Are there any other? I don't see any more questions on the chat. People asking about the CPD certificates, that will come up. My YouTube thing, I will put at the end of the last lecture once I've uploaded them all. If you can search for it, you'll find it as HUDC, Heart Surgery and Dental Care.
Sorry, I have another question.
Please go ahead.
Regarding the swelling one, well, when I tried to do the extraction when they have swelling, but it was not very bad. It was a normal one, like sulcus and around the tooth was. The patient had pain, and the tongue was numb, the lips were numb, so I knew that my technique was completely correct, but the patient had pain that I couldn't continue. So in this case, what usually do you, as an expert, what do you do?
Thank you for accusing me of being an expert, but which tooth was it, Naga?
It was lower right 6.
Yeah, the lower molars. What have you done? ID block?
Yes, I did IFN block, lingual, buccal, everything.
Yes. Oh, okay, right. So yeah, I mean, I would start on a lower 6, which is often the hardest tooth, with an articane infiltration. That's my standard in anaesthetic for an extraction. Articane, buccally, a little bit at the papilla, maybe a little bit lingually, maybe, but generally just buccally. If that's not enough, ID block with lignocaine potentially, and then you start looking at intraligamentary injections. And there are times when it just doesn't go numb. You've got everything numb like you have. You've done everything you can, and you can't. There's a limit how much anaesthetic you're going to put into somebody. And sometimes you do have to give up. Sometimes you can say to the patient, if we can get this out quickly, it's going to hurt a lot, but it's going to help you get better quicker. Sometimes you can extirpate, but sometimes you are stuck. You can't achieve anaesthesia, whatever you do. And if you can't achieve anaesthesia, it's difficult to get the tooth out, especially if it's not. So that, yes.
The thing
Antibiotics are required for this infection.
Yes, the thing is, my colleague who was more expert than me, he said I give him antibiotic, call him in after a week, and I gave him antibiotic, and after a week, when I did the same thing, it was all perfect, and I could do the extraction. So I'm thinking
sometimes the pain is going to go. Sometimes just telling somebody go away and come back next week, and it'll go. you'll achieve anesthesia better. But it's the first line thing is to try and get them numb by infiltrations, intraligamentary, and trying to get that treatment done, because that is what's going to get rid of that problem as quickly as possible. It's not always possible. I appreciate that. There's a question on here about Ledamix being useless for pulpal necrosis. What would I use instead? Calcium hydroxide. If I think I mentioned this on the last lecture, if you've got hot pulp, so this is the case Naga was talking about, where you're trying to extirpate rather than extract and just can't get it numb, that's where Ledamix is useful. It will sedate that hot pulp. However, if you've got an abscess or you've got anything you've got a necrotic pulp, Ledamix isn't going to help. There's another question here. Why is patient both? Okay, that's the same thing. Stop the recording there. Contact details: Scott Aaron, SCOTTAARON@hudc.co.uk. Is there a right and wrong time to try to drain a swelling, Lance? If you see suppuration around a tooth, do you encourage patients to massage the gum? Yeah. Well, the right time to incise it is when it's fluctuant, which is earlier rather than later. But the reality is, it's when they're there with you. Would I encourage patients to do it themselves? Yes, absolutely. If they can burst their own abscess, when we were doing this online, Zoom calls with patients in March 2020, if you get people to burst their own abscess, that will help as well. Would LA be efficient to do X-ray when there's a swollen face? Absolutely, it is. Any LA tips? We've just gone through that one. Does the swelling and infection not interfere with LA working? No, I don't think it does. Well, it does. It does have an effect, but it doesn't stop you. If a pregnant so I'm just losing the. If a pregnant patient has RCT treatment, so I'm losing this question every time I look for it. Do you want to shout out what their question was about a pregnant patient?
Hi, Scott. It's me, Vajiha here. Yeah, so there was a pregnant lady with a root-treated upper right one, and palpation of the sulcus shows that there was non-fluctuant abscess there. So, and she was hesitant to take a radiograph because of her pregnancy. So what are the treatment options as an emergency, or how to actually help the patient?
Okay. The guidelines from the FGDP about pregnancy and X-rays are take an X-ray. The X-ray is going to cause a darn sight less harm than having an infection in your body to the baby. Tell them that. Sometimes the diagnosis isn't as obvious as we think. And I wouldn't normally take routine bite wings when someone's pregnant, but an emergency situation, they need an X-ray. You've got a root-treated tooth. It's a front tooth. They don't want it out. I get that. If you're able to get the old root filling out, well, yeah, it's easy enough in some cases if you've got enough time and enough skill set on it, but it isn't for everybody, and some teeth you just can't do it. If you can't incise because there's no, it's not fluctuant, or it's not even potentially fluctuant, there's not much point just stabbing them for the hell of it. What are you left with? You're left with painkillers. If they're spreading infection, then you've got the option of antibiotics. But if they've not got spreading infection, there's no indication for antibiotics. It keeps coming back to that. Being pregnant, not wanting the extraction because it's a front tooth is not an indication for the antibiotic. It might well get better in 7 days if you do nothing, but it might not. Someone's put on, Adrian, about anesthetic and the acidity, alkalinity of it. Yeah, that's why it doesn't work as well in an abscess situation, in a diseased situation. So you get everything numb except the one tooth you want to work with. It is to do with pH values. Do we have to finish the course of antibiotics? No, we don't. Once the problem's gone away at 2 to 3 days, they don't need to continue the course anymore. They should get rid of the antibiotics that they've got. I think ideally you meant to dispose of them via a pharmacist, but getting rid of them so they don't try and use them next time might be helpful. If one opens the tooth for drainage, is it okay to leave it open? That's not recommended anymore, Bach. Good question. Used to be recommended you'd drill into the tooth, open it up, pus comes out, leave it 24 hours, go back in again and close it. The recommendation nowadays is close it up straight away, because leaving it open, more bacteria are going in than are coming out. That said, there are times when you do in effect do that. For example, you're trying to take a tooth out, it fractures off, and in effect what you've done is a very posh version of open and drain by leaving in the retained roots, and you'll usually get them out of pain. But I would never deliberately leave a root canal open nowadays, although sometimes my temporary fillings fall out. So in effect, I do the same thing, but not deliberately. Could you write your email? Does the swelling always reduce in size with incision? Does the swelling always reduce in size with incision? No. I mean, if it's suppurating, if there's pus in there, yes, it will. If you've got hard swelling, you will tend to find there's no pus in there, so it doesn't really reduce. You try it, you get a feel for which one's which. And when not to try it. But certainly if it's soft, it's fluctuant, it definitely incise it. It doesn't all come out exactly. And it's worth noting when you do that happens. Does anesthetic wouldn't you think about this? And trying to get that's the same question again. Can we please go to the recording? Yeah. Can we drain using the syringe of the suction for extraction and extraction? Yeah, I mean, incising and then referring, well, that depends on the complexity of the extraction, and that depends on the complexity of the extraction in your hands. In my hands, I might be able to take out this tooth, and the next person can't. But the third person along is even better at extraction, to take out more teeth than I can. And obviously, you can only take out what you think you can get out. In an emergency, maybe trying it can be helpful, but it's got to be the right patient and the right try. There's no point trying the impossible. Can we get a recording? This has been recorded, so I will put it online. Recommendations: patients have hypertension. That'll be in lecture 4. Patient going abroad, ask for antibiotics. No. If you've got somebody going to the South Pole, I think a dentist did this week, we might think differently. On a solo adventure to the South Pole, they may well take medications just in case. Somebody going to anywhere vaguely normal where they can get hold of healthcare does not need antibiotics because they're traveling. That's not an indication. Best advice: get it treated before you go. Take painkillers with you. First line antibiotics: phenoxymethyl penicillin for dental infection. Somebody sent me a message about a case that we had in the urgent care clinic some years ago that wasn't about sepsis, but that was a patient who had a swelling relating to an upper 7 or upper 8 that spread, and really and truly, that swelling, the tooth should have been taken out. And in fairness, our dentist said, you need to have the teeth out. But the patient didn't want the teeth out. I can't remember if antibiotics were given or weren't given or whatever it was. But that infection spread, put pressure on the optic nerve, and the patient went blind in one eye. Now, it's a rare case, but this is a case of not treating. And what can go wrong, that rare but worth being aware of. If there's no other questions, I will stop there. Wish everyone a lovely weekend.